Bismillahirrahmanirrahim. Today we will have case quiz number 120. Case data: 52 years old female referred for assessment of possible glomerulonephritis, as we will see in the history and examination. The patient had 3 months history of bilateral lower extremity rash with intermittent right knee pain with swelling, and 2 years history of fevers and sweats. The patient was treated with a short course of oral prednisolone by her family physician with effect, but hair rash and symptoms returned soon after cessation of the treatment of steroid. Examination of the case revealed palpable petechial rash in her lower extremities, moderate effusions in her right knee and ankle which were warm to touch. The remainder of her examination, including vital signs, was within normal limits. Investigations: the patient had microscopic hematuria. Creatinine was 94 micromole per liter, and the baseline for the same patient was only 59 micromole per liter last year. The patient had normocytic anemia with hemoglobin 10.2 gram per deciliter. The patient had mild leukocytosis with white blood cells 11.12. Urine analysis revealed trace proteinuria, and urine microscopy showed 58 red blood cells per high power field and acanthocytes and 7 white blood cells per high power field. ESR was shooting 115 mm for the first hour. C-reactive protein also shooting 94 mg per liter. Rheumatoid factor was high, but anti-CCP was negative. ANA was weakly positive with a titer only 1/80 by immunofluorescence. RNB was weakly positive, but anti-double strand was negative, and lupus anticoagulant also negative. ANCA C3 and C4 were within normal limits, so negative also. A previously arranged biopsy of her petechial rash was consistent with a leukocytoclastic vasculitis, and immunofluorescence was positive for dermal capillary IgM and C3. Arthrocentesis of her knee was not consistent with a crystalline or infective arthropathy. Hepatitis B, hepatitis C, HIV, and syphilis serology were all negative, so it is not one of these infections. Serum protein electrophoresis didn't show a monoclone, and cryoglobulin were negative. Kappa and lambda light chain were minimally elevated at 15.2 and 12.6 respectively. 24-hour protein show microproteinuria with 320 mg per 24 hour. Renal ultrasound show normal side kidneys without increased echogenicity. Renal biopsy by light microscopy we see immune complex mesangial proliferative glomerulonephritis, diffuse global mesangial hypercellularity was seen. Immunofluorescence show trace mesangial IgG and kappa +1 IgM, lambda and C1q and +2 C3. Electron microscopy showed mesangial electron dense deposits. Her pathology findings were felt to be potentially be in keeping with mesangial proliferative lupus nephritis. However, it was acknowledged that clinical and laboratory findings supporting this diagnosis were lacking. Regarding therapeutic follow-up of this patient, the patient was steroid dependent. Creatinine responded to prednisolone but raised again when with steroid tapering, whatever the steroid-sparing drug used. For example, the patient received azathioprine but didn't tolerate due to gastrointestinal upset. The patient received MMF, which alone didn't improve the case in the absence of steroid, and also rituximab didn't improve the case in the absence of steroid. So the patient responded only to steroid, and every time the steroid was tapered or withdrawn, the condition recurred again. So what is the diagnosis? And as usual, we will leave you for 6 days, and the answer will be online on next Thursday. Wassalamu alaikum wa rahmatullahi wa barakatuh.